I'm Dr. Charles Moak with Allure Vein Center. I'm going to talk about our strategy for the veins and make some clarity and make it a clear guidelines and guiding principles of our strategy for veins so that we have clarity, because as we grow and build, we're bringing more people in, we have to really train people. And I wrote a little booklet that you can read on our strategy and our guidelines and guiding principles. There's also a very good article in the S-Drive. It's from 2011. So it's, this is pretty well established. It's the care of patients with varicose veins and associated chronic venous disease, clinical practice guidelines of the Society for Vascular Surgery and the American Venous Forum. So American Venous Forum, we actually belong to the American College of Phlebology. American Venous Forum is the other large varicose vein care, and more vascular surgeons are in that. So Society of Vascular Surgery and the American Venous Forum, and they have a whole big thick article, and it has all their guidelines for treating these patients. It really kind of gives us something to kind of fall back on. This is the consensus of our associations. So the first thing I want to do is talk to you about the treatment of how we've been treating our varicose veins and how our practice came to be. So back in 2004, I was at a conference for something unrelated to veins, and I met a doctor, Dr. Jeffrey Hunt, who had been treating veins with ultrasound-guided sclerotherapy. Not like our MFT we're doing now. He didn't use the foam. He used actually just STS solution. And he was trained by a doctor who was trained in Europe, Dr. Knight. And he invited me out to his office. He had done 60,000 procedures, and his whole practice was built on this, vein procedure. It's kind of interesting to me because I always like things that are easy to help people look and feel better with less risk. So I went to his office and visited him. It was very interesting. He was doing this procedure that was replacing surgery and having almost as good outcomes. Not quite as consistent, but way less risk, no downtime, no scars, no complications. And basically, we would inject the saphenous vein with a solution. He'd give him 3 shots, a cc each, and then he'd inject the varicosities the next week, kind of like we do now with the MFT. And this was before the lasers and the radiofrequency devices were on the market and available. They had just started coming out at that time. And so I took it back to my practice and started doing it, and then I went to some conferences and I read a bunch of papers. I read hundreds of journals on this, and it was really mostly came from Europe, but some in America. And they found if you took the solution and turned it into a foam by adding air, you increased effectiveness by 300%, or 3 times as good. You could see it under ultrasound. And if it extravasated, because it was mostly air, it wasn't really toxic to the tissues, whereas the solution would actually burn and cause little red spots. So what we would do is inject the saphenous vein with foam, I'd give them 3 shots, 3 cc's each, and then we would bring back, inject the varicosities. And then a study came out of Europe showing if you put a catheter inside the vein, a long catheter, like the ones we use for the laser, the long one, and then you temest the vein and make it smaller, you could actually use like 3 cc's of foam and pull the catheter out and ablate the saphenous vein. And it worked pretty good. In fact, there's a FDA-approved solution called polydocanol that's used for that, and it's not, insurance companies don't pay for it right now, but it's a procedure that's kind of being reintroduced using chemical ablation. Well, that was working pretty good, and then lasers and radiofrequency were coming out, and they were shown to be equally or maybe more effective perhaps, but the interesting thing was insurance would pay for the lasers. They wouldn't pay for the foam. We were charging cash, but they would pay for the lasers and radiofrequency. Studies came out showing that the laser and radiofrequency devices were at least as effective as surgery. The surgical procedure had been where they would cut the vein out. They would actually take it and make an incision in the groin, do what's called a ligation, tie it off, and then strip the vein out. And then they do a procedure for ulcers called SEPS, subfascial endoscopic perforator surgery, where they would take and use a laparoscope and clip the perforating veins, really complicated surgery, to make it so that the ulcers would heal. Our hospital was doing that when I was learning about the lasers, which was interesting. There's a new procedure for them. So the lasers, they would do the exact same thing. They'd go into the perforator vein and go into the saphenous vein, burn them basically, and then inject or do phlebectomies on the varicosities. Well, this looked interesting. Insurance would pay for it, so I thought it'd be a bigger market, so I started accepting insurance and learned how to do the laser procedures first, and then later radiofrequency. And what happened is that in Michigan, we were the first ones doing it, really kind of the first in the Midwest, and we got all these patients coming. We got incredibly busy with it. We were doing, at the time, just in the Shelby office, we had 6 rooms, and we were doing about upwards of 40 procedures a day, at least 30 ablations a day. And then things changed, moved on. We started getting competition. A lot of doctors that were doing stripping before started offering ablations in their practice, and of course it grew and took a little business from us. And really we went from like doing 30 or 40 a day down to doing like 10 or 15 a day. And I realized, okay, people that were driving from across town can no longer come to see us because they're going to pass 10 other vein practices. So we opened an office in Livonia, and that kind of brought our business back up. And then we started looking at the pressures from the outside and really what our core customer is and what our options are. And everybody in our market was going after the beautiful leg. The lady or man who had a normal looking leg and had a big giant varicosity, and we would ablate the vein and treat the varicose veins, and they felt better and they're happy. And some outside pressure started happening where some insurance companies were maybe considering no longer paying for varicose veins that didn't have skin changes or didn't have ulceration, because those are like the worst patients, and most people were just focusing on the pretty legs. Well, that hasn't happened yet. Most insurers cover all varicose veins, but it'll happen in the future. Medicare is looking at that now. So I thought, well, to be prepared for that, I'm going to start thinking about treating ugly legs, because they actually have more disease. They have more perforated veins, they have more veins to ablate, so it's kind of fun, we like doing that. And actually have more improvement, because when they get sent to their doctor, they'll send them to the wound care center, when in reality if we'd ablate them, they'd feel better right away. And so we started switching our model to the ugly legs, and we got a bunch of ugly leg patients coming in, and we're treating people who are a little sicker, obviously. People with ulcerations have more disease, a little more obesity, more hypertension, more heart disease. So they're going to be a little sicker, but this is something we can offer them that's extremely low risk. There are no contraindications to it. None. I've been hearing about non-candidates. There's really no such thing. That's a myth. And I want to kind of set the record straight on how we're going to go about treating. What are the standards of care? So go for the foreseeable future. We're going to pursue this ugly leg concept, and I'll tell you why in the next video. But this is an extremely important public health issue, leaving these ugly legs ugly. Thank you.